Hello, everyone. My name's Eileen Regan. I'm the CCO at Examen, and it's my pleasure to welcome you to the 6th webinar in our male fertility series. The webinars take place on a monthly basis, and each month we're joined by an expert in the field of fertility treatment or therapies. The event's open to all, and we have a wide range of participants joining us from academics, HCPs, urologists, embryologists, fertility specialists, as well as the men, women, couples and individuals who are on their own fertility journey. The views presented in the webinars are the views of our speaker and not necessarily of the company Examen. And tonight's webinar, we're doing something a little bit different from the previous, whereby we're moving away from the broader themes we've discussed, like paternal age and nutrition, to the individual approach taken by one fertility clinic, in this case, Aria Fertility Clinic. And we're going to hear from Francisca Mora, clinical embryologist in the new Aria Fertility Clinic in London, and how they interpret the latest evidence about sperm and turn it into pathways for patients. So you're all very, very welcome to join us today. And let me now introduce you to our speakers. So our chair, Professor Sheena Lewis, is the founder and CEO of Examen and an honorary professor of Queen's University Belfast, where for the past 25 years, she has dedicated her research into novel tests for male infertility. She is currently an executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She has published over 100 full papers, as well as numerous book chapters and reviews. She has been past chair of the British Andrology Society, UK National Representative and Chair of the Andrology Special Interest Group of ESHRA, and Embryology Executive Member of the British Fertility Society, and was also a founder member and Vice Chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where it markets its exact range of male fertility tests powered by the Sperm technology, which is now the market leader for sperm DNA damage testing in the UK and Ireland. Our speaker today is Francisca Mora, who graduated from the University of Coimbra, Portugal in 2014 with a degree in biochemistry, after which she started to become quite interested in the field of assisted reproduction. In that year, Francisca enrolled on the biochemistry master's degree at the University of Porto in Portugal, having conducted her master's thesis research project on the topic of oxidative stress and male infertility at the Assisted Reproduction Unit of the Central Hospital in Coimbra, together with the Reproductive Biology and Stem Cells Group at the Centre of Neuroscience and Cell Biology in Coimbra, Portugal. Francisca got the opportunity to work at an IVF clinic in London, belonging to one of the biggest IVF groups in the UK. And in 2021, she joined the embryology team at Aria Fertility. She is an ESHRA certified clinical embryologist and combines her clinical work with research to improve the understanding of embryology to improve patient outcomes. So thank you to both of our speakers for joining us. And just before I hand over, just want to run through some housekeeping. So I'll hand over shortly to Sheena, who will do a short introduction to our speaker and to Examen, and then hand over to Francisca. And at the end, we will have about 10-15 minutes for a Q&A with both Francisca and Professor Lewis. So please do pose your questions throughout the talks using the Q&A panel. Please don't use the chat. If you could use the Q&A, it keeps it easier for us to track the questions. And you'll also have an opportunity to rate those questions, and then we'll make sure that we focus on the most important ones during the Q&A session. If you experience any technical issues, use the chat and we'll do our very best to help you. And just to let you know that attendees will be muted throughout and videos enabled for our speakers only. So all the events in the series are recorded and made available on the events page of the Examen Lab website following each session, and it'll give us 24 hours to get that online. Also, one CPD point will be awarded for attendees for the 1-hour event, and a certificate circulated a couple of days after the event. So at the end of the session, you'll be invited to rate it. Please do so. All of your feedback is always very valuable for us and helps us improve future sessions. So without further ado, I will now hand over to our chair, Professor Sheena Lewis, just to start the session.
Okay, great. Thank you for your patience. So, as you've already heard, tonight we're going to be talking about what we actually do with information like the information which Francisca has found on the web and through papers and all the things that we publish as academics, what actually happens to them? How can they be used in the clinic? And that's sometimes a very difficult question for all of us. And certainly I've been sitting on the SCAT committee for a number of years now, where we look at clinical advances, scientific advances, and see what is in the best interest of patients. And I'm sure many of you have heard of the traffic lighting system. So in terms of our company, our mission and vision are to raise the awareness of male infertility and to provide men with knowledge and advanced testing, and to demonstrate that by optimizing sperm health before treatment, we can improve fertility outcomes. We know that inadequate testing in the past has led to poor treatment decisions and poorer outcomes. And we also know that if we can bring some innovative tests into the fertility laboratory and fertility clinic, then it's likely to create better success rates for us. And of course, that's what clinics and patients and scientists all want to happen. They've got exactly the same objective. In our company, we've been around for 10, 11 years. We started off as a spin-out company from the university, and it was really dependent on some of the papers that we published that people started to write and ask me if they could have the tests. And at that stage, we didn't have commercial tests. So we decided this was an opportunity to set up a commercial company where we could provide the tests that the public clearly needed. And over the years, we've expanded the lab, and we've got ISOs, first in 9001, then in 13485, and now we're working towards our IVDR. Why would you want to use our test? Well, because they can diagnose male infertility more accurately than the Semen Analysis. They can predict the likelihood of fertility treatment success, and they're based on many, many publications over many, many years. And we hear from others that we have good customer service. So I suppose that's another reason why people want to use us. We're very much in one of the leading diagnostic tests within the private sector now, and about 80% of fertility clinics in the UK and in Ireland are using us. I think one of the things that the exact tests allow us to do is to give men back control of their fertility and to allow them to be equal players in their journey. This hasn't always happened, and actually I think ICSI has been one of the ways which has pushed men to the side, where we're not actually interested in men for their own sake, but we're much more interested in men just as a way of getting a sperm, just a sperm donor, and then everything else is to do with the egg and the embryo. I'm very glad to say that over the 20 years when we've been doing all this research, we have finally got to the stage now where we're in a number of international guidelines. In the European Association of Urology, they are now suggesting that more complex testing and a semen analysis is required, particularly if men have unexplained infertility or if the couple is suffering recurrent pregnancy loss. The same thing is true from the ESHRE guidelines for recurrent pregnancy loss. And again, there's a suggestion that the best clinical practice is to test the men as well as the women. And then probably one of the most exciting things that's happened to us was very recently when the WHO new laboratory manual came out. They have included for the first time that DNA testing could constitute an important addition to the workup of male infertility, and it's becoming one of the most promising biomarkers in basic and clinical andrology. And that, of course, is music to our ears because it has taken quite some time and many, many publications to get to this point. So tonight, as you've heard, we're going to have Francisca talking to us, a very young, passionate embryologist who's doing some great work, and we're really looking forward to what she's going to say. One thing I would say in advance of her talk is that things have changed hugely in the fertility area over the last few years. When ICSI came in 1995, it was a wonderful intervention because it was the very first time that we were able to do anything for men, but it had very much its downside in that it really was a death knell for research in male infertility, because everyone said, well, we can do ICSI, we can bypass the problem. We don't really need to know what's wrong with men. We don't need to know what's wrong with their sperm. Now, quite a number of years on, we realize that we're not getting 100% success, and there's still many things that we need to do for men in order to improve their success rates. I always say we've gone from the empowerment of men to the emasculation of men, and now what we want is the equality of men. We want men and women to be able to talk to their healthcare professionals as a couple and have equality in couple care. Now tonight, I understand Francisca is going to talk to you about 4 tests that they use in the Aria clinic. Sperm DNA needs no introduction. It's been around for quite some time, and we know quite a lot about it. The other 3 tests are slightly more novel in terms of microfluidics, PIXI, which I was very involved in the randomized control trial, and also IMSI. So we'll hand over to you now, Francisca. The floor is yours. Do tell us what you do for men on their fertility journey. Thank you.
Thank you so much. So good evening, everyone, and thank you so much, Eileen, for the kind introduction, and Professor Sheena Lewis for introducing the topic of my presentation tonight, which will be based on the male fertility assessment that we conduct at Aria Fertility. And I will carry on to explaining how we in the lab and in the clinic integrate the information to manage male infertility in the laboratory at Aria Fertility in London. So tonight I will briefly cover the topic of infertility, and I will discuss a little bit further certain factors that can lead to male infertility. I will then explain how we do at Aria our sort of conventional semen analysis, and then I will carry on to explain how we conduct our male fertility assessment and which treatment pathways can we draw from it. And I will finish by just explaining briefly and showcasing an example just to illustrate a bit better what I'm trying to convey tonight. So infertility is known to affect around 48 million couples and 186 individuals, according to the World Health Organization. And there are sort of 3 main factors that lead to it. 35% of the cases can be due to female factors, other 45% due to male factors, and the remaining 30% due to unexplained reasons. So in these cases, consultants and patients are not really able to reach a conclusion as to why the infertility happens. And as everyone is quite aware, the COVID-19 pandemic unfortunately created quite a massive impact on the access that patients actually have to the infertility treatment. And so this even brings more to light on how important it is for us to tackle infertility nowadays. As for male infertility, around 40% of infertile men have no clear etiology, so the reason as to why they are infertile cannot be achieved. As for the 60%, there are several reasons, and I'll just here briefly mention a few. So there could be genetic causes. For instance, the Klinefelter syndrome, which affects around 40% of infertile men, whereby men have an extra X chromosome instead of just one X and one Y, and this will affect the production of sperm cells. And for instance, patients that suffer from cystic fibrosis will have the so-called congenital bilateral absence of the vas deferens, which are the tubes that carry the sperm out of the testis. And therefore, there's sort of no obstructive ozoospermia. So when we assess the ejaculate of these patients, we cannot find any sperm cells. It's not that they don't produce, it's that they don't have the tubes that carry them out. There could be also hormonal reasons, for instance, low levels of testosterone, which will affect the semen production, the production of sperm cells. And then, for instance, the presence of infections. Around 50% of males actually have infections and they are asymptomatical. So they have no idea that they have an infection. It is especially prevalent in young sexually active males. For instance, infection with gonorrhea and chlamydia are known to cause obstructions in the epididymis, and this again can affect the travel of the sperm through the male reproductive tract. Also anatomical reasons, for instance, the varicocele, whereby veins within the scrotum enlarge and cause an increase of temperature in the testicle, which will again affect the production of sperm. And also lifestyle reasons, which this topic has been quite debated over the last decades. For instance, the exposure of patients to solvents, radiation, also the consumption of drugs. This will always have an effect in the fertility. And there is an increasing concern, again, in the last decades over the fact that there is more than well-known decline in the sperm counts, especially in the developed countries. And if we take together this with the fact that the age at which patients come through for treatment is increasing, this sort of really makes us prioritize and sheds light to the fact that we need to also draw our attention to the male factor. And as Professor Sheena Lewis said, the male is often overlooked, and we really need to assess and tackle male infertility as much as possible. Now, one of the ways for us to really assess and check if one of the tests is part of the male assessment when any patient comes through for treatment at Aria Fertility is for us to conduct sort of a conventional semen analysis, whereby we will check macroscopic and microscopic parameters of the sample produced by the male patient. And according to the World Health Organization, which, as again, Professor Sheena mentioned, has just released the 6th edition of their laboratory manual, these values have been reviewed and updated this year. And so there are sort of these thresholds that the samples need to meet in order to be considered as normal, so as having a higher chances of leading to pregnancy. Now, if we take in consideration these 4 main parameters that I have selected, so concentration, which is sort of the number of sperm cells that we see in the sample, progressive motility, which refers to the percentage within the sample of sperm cells that move in with a clear trajectory in a defined way and in a fast way, the normal forms, also known as morphology, normal morphology, so the way the sperm looks, the shape, and as well the presence or absence of anti-sperm antibodies. So if we look at these main 4 parameters and without assessing anything else, we can draw sort of very few conclusions in terms of treatment. So if these parameters are all within normality, the consultant, and again, this will also depend on the medical history of the patient and the couple, but could potentially advise for a intrauterine insemination or in vitro fertilization, conventional IVF. However, if one of these parameters or all of them are altered, then the advice would be to perform the intracytoplasmic sperm injection as the method of insemination. Now, I will just briefly show the difference between these two. So for the conventional IVF, what we do is we place, so as you can see, there's this sort of fluffy structure that contains the egg in the middle, which is sort of this shiny structure, sort of dark gray structure here. And we place together the eggs surrounded by cumulus cells together with the sperm that has been previously prepared. So this is a population of sperm within the initial sample that the patient produced that has the best motility and better morphology. And we just allow the sperm cells to fertilize the egg overnight. We don't intervene more than this. As for the ICSI, what we'll do is we'll remove these surrounding cells that we had in the IVF video, and we'll then again prepare the sperm in the same very similar way. And what we'll do is, under a microscope with high magnification, we'll select the sperm that we think looks best, and with an injection pipette, we'll place each sperm cell inside each egg. Thereby, we can bypass any issues that the sperm might have in accessing the egg. However, there's sort of many steps that still need to happen within the egg to achieve fertilization that we do not control. But this is sort of the main difference between these two insemination methods. Now, with the conventional semen analysis that we conduct at Aria and in any other clinic, the sperm functional competence is not really assessed. So we are not really going that further in terms of detail. And here is where the male fertility assessment comes to play. And at Aria, what we do in this assessment is we will conduct a conventional semen analysis, exactly like the one I just explained, but we'll do 3 extra tests. So we'll assess DNA fragmentation, which we do in partnership with Examen. We'll then do as well perform a semen culture and the Hyaluronan-Binding Assay. And I'll just now explain a little bit each technique. As for the DNA fragmentation, as the name indicates, so what it means is that the DNA within the sperm cells has sort of these breaks on it, either on one of the strands, DNA strands, or on both, and can be caused by several factors, mainly the presence of reactive oxygen species, so oxidative stress. DNA fragmentation can happen due to the normal processes within the sperm production, but can also happen due to exposure to radiation, chemotherapy, toxicants, as in patients that are heavy smokers, and also air pollutants. And if we take in consideration that, as this study indicated, that eggs of females younger than 45 years old are actually able, when after fertilization, to repair around 40% of the damage of the DNA brought by the sperm. However, eggs of females older than 45 years old are less effective. And this just really emphasizes on how it is important to tackle this issue, as if both gametes have DNA fragmentation, especially the sperm, this is known to impact embryo development and to lead to miscarriage. And in fact, a study concluded that male partners of women who had miscarried actually had higher sperm DNA damage levels than fertile men. And at Aria, one of the sort of other treatment options that we like to explore with our patients is, in this case, we use the microfluidic based sperm preparation. So the sperm can be prepared in the so-called standard way for the assisted reproduction techniques, which involve several steps of centrifugation. And these are known to increase the levels of reactive oxygen species within the sperm. And as I said before, these can lead to DNA fragmentation. Now, one way to surpass this is to prepare the sperm with a microfluidic device, whereby we place the sperm into a chamber, and in this sort of upper chamber, what we'll do is there's a pore structure that will only allow sperm of a certain morphology to be able to swim upstream, and also sperm with better motility will swim. So we'll in the end we'll achieve a population of sperm with quite a really good quality. And this by using this device, we are eliminating any of those classical centrifugation steps that are involved in the normal preparation of sperm. And in fact, a study concluded that the use of microfluidic device allowed for selection of highly motile sperm with almost undetectable levels of DNA fragmentation, whilst another study concluded that it was obtained a far higher euploidy rate for day 5 embryos that had been created with sperm prepared by these devices versus sperm that was prepared the conventional way. And euploidy, for those who don't know, means that the embryos had the right number of chromosomes, the correct genetic makeup. As for semen culture, so if there is a presence of an infection, asymptomatic or not, and if this infection is either in the level of the accessory glands or the genital tract, will cause an increase of number of leukocytes within the male anatomy, and this will lead, as the leukocytes produce a high level of reactive oxygen species, these levels will massively increase, and they can even cause damage in the DNA, as I said before, but also at the level of the membrane of the sperm. Now, one way to sort of assess if, in fact, there is any bacteria within the ejaculate is to perform a semen culture. And And what the semen culture will tell us is whether or not there is presence of bacteria, and if it is resistant to certain antibiotics, especially to the antibiotic that we use in the lab in our media. And this is the one that interests us the most. Now, if there is a very limited time scale between when the patient does this semen culture and the actual treatment, then we'll perform ICSI. It will be the advised insemination method. In case the bacteria is resistant to gentamicin, which is the antibiotic that we use. However, if there is a larger time scale, then the consultant will most likely advise the patient to take antibiotics, and then another semen culture will be performed to assess if they were effective. Lastly, I will just talk about the Hyaluronan-Binding Assay that we perform. So when I mentioned when I showed the video of the conventional IVF, so the eggs were enclosed within the cumulus orphus matrix. So this matrix is composed by hyaluronan. I would say that most people have heard of it more in the cosmetic side of things, but it's actually a natural component. And we can actually use it to sort of differentiate between mature sperm and immature sperm. Mature sperm have hyaluronan receptors, so they will attach to hyaluronan. And this makes sense because if the sperm in vivo, the sperm needs to be able to cross this cloud of cells to reach the egg. So it needs to be able to interact with it. Whilst immature sperm actually does not attach to hyaluronan. And immature sperm is actually known as well to have higher levels of normal morphology and lower genomic integrity. And what we'll do, and I'll just quickly show in this video, apologies for the noise. So the sperm that is attached to the hyaluronan is the sperm that is sort of just rotating on each other. Instead of having a progressive motility, it's just stopped but rotating with the tail. And this is how we know that the sperm are mature, because they are able to interact with the hyaluronan, whilst the sperm that is swimming freely is considered to be immature. So what we'll then do is we'll sort of calculate how many sperm we counted that is attached to the hyaluronan versus the total number of sperm cells. And if this score is lower than 65%, what literature tells us and what we at Aria will do is we'll suggest PIMSI as the preferred insemination method. And PIMSI sort of is a conjunction of two different techniques. PICSI technique, which is the physiological ICSI, whereby, so instead of just selecting a sperm cell that is swimming in our sort of ICSI dish under the microscope, we'll select a sperm like I'm showing here in the video. So a sperm that is attached but rotating around each other. Because these sperm, we know that they are mature. And then we'll check as well, and this is where IMSI comes in. So the morphologically, intercytoplasmic morphologically selected sperm injection, so whereby we'll take into consideration the morphology of the sperm to a higher level. So this is done with a higher magnification objective that allows us to check the sperm into more detail. So if we combine both techniques and taking in consideration that PICSI in this large randomized control trial and in several other studies, as it's known that PICSI leads to a reduction in pregnancy loss rate. And as for IMSI, miscarriages rates have also been decreased by the use of IMSI. So both techniques have not been proven to increase the chances of a live birth and to have a baby, but they do decrease the chances of miscarriage. And this is why at Aria we advise for, or we at least explore this option with the patients. So as for this male fertility assessment, who can benefit? So any patient really, but mostly patients that have had, or couples that have had previous miscarriages, where the male partner has urogenital infections or known unhealthy lifestyle habits, for instance. As for the treatment pathways that we offer at Aria, so considering that the patient does the male fertility assessment, And if the conventional semen analysis comes back as being normal and there are normal levels of DNA fragmentation and hyaluronan-binding, then IVF might be the suggested insemination method. Again, here keeping in mind or not considering really the female history, because that obviously needs to be taken into account by any consultant and any patient. Now, if in the semen culture, this comes back as being positive and resistant to the antibiotic, or there is a presence of anti-sperm antibodies, then ICSI will be suggested. On the other hand, if there's a abnormal semen analysis, and on top of that, there is sort of the sperm count is very low, or even we cannot even see any sperm, then we at Aria offer as well what we call the single sperm vitrification. And this is sort of a very tiny device. And when the patient needs to come through for sort of to freeze his sample to be used in the future. And what we'll do is we'll go under the ICSI microscope, which has a high magnification, and we'll see any sperm that we see moving and with a nice, good enough morphology, we'll grab that sperm and we'll place it in this tiny device. And this device is straight away frozen. And in the future, when the patient comes for treatment, what we'll need to do is we just need to thaw this device and straight away place it in our ICSI dish and just move on and do the ICSI. We don't need to sort of fish the sperm. The sperm is already there, the best one. And this is, and by this, we'll have to use ICSI as the insemination method. Now, if whenever we do the DNA fragmentation, if high levels of DNA fragmentation are reported, then one of the approaches at Aria is to prepare the sperm with a microfluidic device, as I mentioned before, and then potentially perform ICSI. However, if the hyaluron-binding is less than 65%, then PIMSI could potentially be the suggested insemination method, especially if there is a history of miscarriage. Now, as Professor Sheena mentioned before, these methods that I have here underlined, they are not necessarily recurrent in every single clinic. It's something that Aria offers, and we like to explore these options with our patients. And ultimately, it is a consultant. The consultant will suggest what he or she thinks is best for the patient or the couple, and ultimately is the patient's decision, obviously. Finally, I would just like to briefly explain, show an example of how can we conduct this male fertility assessment and which conclusions can we draw. So if we take into consideration the semen analysis results, which all fall within the normal range established by the World Health Organization, if we just sort of looked at the conventional semen analysis, we would, and taking into consideration everything is normal, our recommendation would probably be to do a conventional IVF. However, if we want to take things a little step further, semen culture was performed in this case. Actually, there was no bacteria found or no growth. Everything was fine. So again, IVF could potentially be an option. But then DNA fragmentation was assessed, and actually two values within the report came as being outside the range. So ICSI was actually suggested. Now, we are sort of completely moving away from a parameter an insemination method as IVF, whereby the sperm parameters need to be really good to achieve fertilization. And now we are moving for slightly more invasive technique, as in ICSI. And then finally, Hyaluronan-Binding Assay was conducted, and the result, the score actually was 59%. So this is below the threshold. So in this case, what we would advise at Aria in a scenario like this would be PIMSI, as to maximize the chances for the patient. So this really just illustrates how, from simple conventional semen analysis versus male fertility assessment, how the conclusions drawn can be quite different, and how it is important to assess the sperm function. So just like to briefly recap that, again, conventional semen analysis is something part of any patient's journey in an IVF. It's something that all clinics do. However, it doesn't go as deep as to assess the sperm function. And this is something that we would like to offer at Aria in order to provide a tailored treatment to maximize the chances for our patients. So thank you so much for your attention, and I'm happy to answer any questions.
Talk, and you've given us a lot of information to think about. We have a couple of questions here, and I'll tell you what the first one is. And again, this person's saying it's a lovely talk, so well done. What evidence exists to assign ICSI with anti-sperm antibodies?
So the evidence would be more towards the fact that so whenever we see the anti-sperm antibodies, pardon me, what we will see under the microscope is that the sperm tends to agglutinate on each other. So there is less free sperm, less sperm is available, even if the sperm is actually motile, so, and more than capable, but the sperm sort of are stick to one another. And in IVF, as I showed in the video, we need to have the sperm freely swimming around, ready to meet the egg. And if the sperm are all clumped together, then we are not allowing that. Now, when we do ICSI, we will still see that, even though with the sperm preparation, it will sort of separate those agglutinates from the actual population of sperm that is free, but will really diminish the number of free sperm. And that ultimate preparation will not meet the required levels for an IVF to be recommended. Whilst with an ICSI, we don't need those many sperm cells. We need actually very few. And we'll be able to assess into detail and to be able to select them properly to then inject each sperm with the most adequate sperm.
Thank you. Thank you. Okay, we've got another question here. If the semen parameters are reduced or presumably are abnormal, do you refer your patients to a urologist to try and fix the causes of the abnormality before fertility? Or do you think that would improve the couple's chances of natural conception or improve their chances of assisted conception if you were to do that?
It's a very complex question because we sort of cannot draw so many conclusions simply by the semen analysis. So the consultant will have to have sort of previous medical history. For instance, if the patient has any genetic condition that affects the sperm production, then, for instance, taking antioxidants or any sort of other therapy will not do anything because it's a genetic cause. So we really need to take a better look at what is behind it to see if there is anything that the patient can do and if there is a need to actually consult a urologist.
Mm-hmm. Okay. Yes. Okay, so there's another question here, which I think is for me, and alas, I don't think I know the answer to it, because it said that this couple has had DNA testing. The results weren't quite normal, but they weren't too bad. And the couple doesn't drink, they don't do drugs, they're healthy weight. They've already had 3 rounds of ICSI, but they've never got pregnant. So what's the problem? And I wish I knew the answer to that, because in 7 years, they've been trying to get pregnant with 3 rounds of ICSI. It's never happened. Can you think of anything else that they ought to do?
Well, I think one of the main things that we need to think, and this is sort of a challenge for us embryologists as well, is, for instance, if we do ICSI, as this couple has done, so we are bypassing any issue that the sperm might have to just communicate with the shell of the egg and get inside the egg. However, once the sperm is inside the egg, either by ourselves or done by conventional IVF, there's still a lot of communication steps that need to happen between the egg and the sperm. And these are steps that we cannot control. Usually what can be suggested in cases where patients have done ICSI and there's been no eggs fertilized the next day is to use what is called a calcium ionophore. So is basically a substance that will trigger the event that leads to the fertilization. But again, I don't know such in detail the specific case. But unfortunately, we are still a little bit far behind to assess things in such a molecular detail.
I agree. I think what I would recommend is that you as a couple go to see a urologist, because there may be things that are missing. There may be things that perhaps your husband has in his clinical history, or in a clinical examination, he might have a varicocele. Something might be done to resolve whatever the problems are, to bring your DNA right back into a better state. I know you're saying it's not too far under the limits, but if you can move it over into the fertile range, then the hope is that you will have success with ICSI. So that would be my advice, to go along and for your partner to have a clinical history and a clinical examination done. Now, can I ask you a couple of questions? DNA damage, antioxidants. If a lot of DNA damage is caused by oxidative stress, as you've suggested, and I would agree, what could you do? Is there anything that you could do to reduce the amount of DNA damage the person has, as opposed to use microfluidics, which may or may not improve the quality at the other end?
Well, it's true that microfluidics, it's a very recent technology and only now it's started to be introduced in the UK. So our consultants at Aria, again, this also depends on the time scale between when the patient comes for the initial appointment to when the patient aims to start treatment. But sometimes, especially where in patients that do not have the sort of the healthiest lifestyle habits, what our consultants always recommend is during the period or the 3 to 6 months before treatment to try as much as possible to have a healthy lifestyle, healthy diet, to exercise. Some patients need to sort of sometimes lose weight in a healthy way, obviously, just to get to their BMI into the healthier range. And also some consultants at Aria will recommend taking antioxidants in the forms of pills, as to, especially if, again, there are 3 to 6 months, as these are in literature are proven to improve the DNA fragmentation levels. So that would be a very holistic approach.
Yeah. Okay. One topic I just thought I would raise, because it might be of interest to people who are listening this evening, is the WHO. You were looking at the WHO criteria, and I'm actually writing a lecture at the moment on how the WHO criteria for normal semen has changed over the years. And as you know, we're at the 6th version now of the WHO, and it started off, I don't know, quite some time ago, 1980s, and now 40 years later, every time we get a new group of parameters from WHO, they're lower. So it used to be, it was 20 million per mil was normal, and then now it's 16 million per mil. So if we thought that semen analysis wasn't a really good and accurate way of measuring a man's fertility to start with, now it's even worse in a way, because people with worse and worse semen parameters are being gauged as normal. Have you anything to say about that?
I think it also proves the fact that the decline in male fertility that has been very much talked about in media and in many scientific articles actually is quite evident. I remember that since the 2010 edition to this one, sort of the threshold for a sample to be normal in terms of concentration has increased by 1 million, but the progressive motility has decreased by 2%. Yes. So this means that we need to work with what we have, and what we have, unfortunately, is decreasing compared to the latest editions. Yeah. And I think that's something to give us food for thought.
Yeah, and I think it's a problem for people who, you know, if they have normal semen by the WHO standards, then they're given IVF. But it wouldn't have been normal 10 years ago, but exactly. It's deemed normal now. So actually, you're even less likely to get success. And I think that some of those pointers are some of the things that have happened. You know, we have hoped for 20, 30, 40 years that we're going to improve our success rates and it hasn't really happened. If we look at ESHRE and we look across Europe, really our success rates haven't improved as we might have expected. And I think there are all sorts of factors that need to be fed into that, but certainly the man is one of the factors. Right, I've got another question here. Oh yes, can you please comment on frequent ejaculation and DNA fragmentation? So what do we know about abstinence times?
Well, what we at Aria actually are recommending, especially when patients come through for treatment, is if in their previous conventional semen analysis, the results for the general parameters were normal, so the sample was considered to be within the normal range, we would recommend to have just 1 day of abstinence before the treatment. As we know from literature that we'll probably get less count of sperm, but the motility will be better. And that's something that we want, especially if the patient on the next day is going to have an IVF, for instance, where motility is very important. For instance, if a patient has had an infection, one of the suggested therapies is not only the antibiotic, which needs to be obviously provided by a consultant, but to have frequent ejaculation. So that has been proven to improve parameters. I would say anything between 1 to 3 days would be the ideal to decrease.
And the other thing, which I think some clinics are now using as well, is ejaculations the previous week. So that in order for the man to clear his epididymis of all the old sperm, not only should he only abstain for a day before the sample that he needs for his treatment, but also the previous week. The whole idea of storing up sperm is a bad one. Really, you should be getting rid of all of those old sperm and only the fresh ones being used in the ejaculate for his treatment.
That's true. That's something that we are trying to bring to light as much as possible to patients, because unfortunately society has exactly the opposite idea.
Correct.
They think that just
throw them all
actually
up.
The fact that the good sperm are in contact with that super old stored sperm is not a good idea. We'll just pass all the reactive oxygen species to the good sperm, and we really want to avoid that.
Yeah, agreed. I've one last question for you, and this is just about infection, because I think it's very interesting what you're saying. How many of the men that you look at their sperm and they have an infection, and 50% you're saying have infections, which is really new to me and shocking. 50% of men have infections in their semen, but how many of those are antibiotic resistant?
Well, so the percentage I provided in my presentations is from a study. It's not
sure.
Our patients at Aria.
No, but assuming that was right. Yeah.
As for the antibiotic resistance, to be honest, I don't know a percentage per se. It's something I don't see it very often here in the lab. Rarely something that we see. But obviously can happen, and especially if patients have been taking antibiotics for another reason. We all are aware with the increasing problem of the overall resistance of bacteria to antibiotics. So I don't know if that could be a factor, but it's not something I would say, at least here at Aria, that I've seen very, very often, to be honest.
Okay. And I thought that was the final question, but one more. And this question is, do you think that you should use testicular sperm or surgically retrieved sperm for patients who have high DNA damage? And that's quite a controversial one in the UK.
That's a very controversial.
I'm not asking it. Who's asking it?
I'm not too sure, to be honest, because at least in my practice, both here in the UK and in Portugal, we've only went to look for testicular sperm in very extreme cases. Not in cases where the patient was able to produce a normal sample. It doesn't have to be normal in terms of all parameters, but at least with a high enough number of sperm cells that we don't need to go for the testicle. It definitely gives us food for thought in the sense that the testicular sperm, the main disadvantage for us embryologists is that sperm is going to be immature. That sperm is not mature. And we do know as well that when sperm goes through an immature stage to a mature stage, DNA fragmentation in a way is normal to happen, as in the normal substitution of the isotonians for protamines. So I don't know if the logic behind would be because that sperm has not undergone that process, the DNA will have lower fragmentation or not, but all I can say from my experience that is something that has only been done in more extreme cases, in cases.
Yeah. Well, if I could just add what I know from the literature, I know that in America, there are a number of studies that show that the sperm from the testes has much better DNA and that a huge amount of the damage happens in the epididymis. So
yeah, that's what I imagine.
say you're going to have good sperm in your testis and you've had 4 cycles of failed ICSI with your ejaculated sperm. What's the option now? What can you say to that couple? What are the options for them? Donor sperm, is that the only option, or what should they do?
Well, again, I don't think donor sperm is something that we really advocate, because obviously there are so many implications, both psychologically, emotionally, financially. I would say that's sort of a really extreme scenario. Besides sort of any conclusions that we can draw, as I mentioned, with the male fertility assessment that we conducted at Aria. So either using the microfluidics device to prepare the sperm, even combining that with the use of PIMC, see if that actually improves. If it doesn't improve, we are always open to explore new therapeutic approaches. And maybe it is a sperm in the sense that it has lower DNA fragmentation than sperm that has been through the epididymis. Could be something to look into. I haven't come across that, to be honest, for those reasons.
Yeah.
But
well, I know there are certainly clinics in London that do that. I'm not giving an opinion one way or the other, but I'm just wondering what you do with the couple who've had 3 or 4 cycles and they're absolutely brokenhearted, and what else can be offered to them. And that's we know that lots of things that start in America end up in the UK and in Europe. So we'll watch this space. Eileen, do we have time for one more question?
One more.
Okay. What evidence? Oh no, have I said that? No, that was with antioxidants. Oh no, sorry. Oh, this is just another compliment for you, Francisca, and I certainly seconded. Lovely presentation. That's with the last comment. So we'll leave it at that. Thank you very much.
So thank you both. Can you see the screen okay? So thank you to our audience for the lively discussion. Thanks to Sheena and Francisca for participating and for the excellent talk. I just want to, before we all leave for the evening, I just want to make sure you sign up and let you know about the next events in the series. So on Tuesday, October the 5th, we'll be joined by Sandra Esteves, a board-certified urologist and consultant in assisted reproduction with over 25 years of clinical experience in all areas of reproductive medicine.
And look what he's talking about.
Indeed, very timely. So we'll be able to answer that question. I think maybe save that question, and certainly Sandra will be the person to answer it. He'll be discussing the use of surgically removed sperm in fertility treatments. And we've got 2 webinars then in November, one at the start of the month and one at the end of the month. At the start of the month, on November 2nd, we're joined by Professor Peter Humaden, specialist in reproductive endocrinology, professor at the Fertility Clinic in Skive Regional Hospital, Aarhus University, Denmark, and honorary professor at the Odense University in Denmark. And he is joining us to talk about the links between lifestyle and sperm DNA fragmentation. And then our final event before we wrap up for the year, on November 30th, we're joined by Professor Andrea Salonia, Professor of Urology at the University Vita Salou San Rafael. He's also the Director of the Urological Research Institute at the IRCCS at Hospital San Rafael. And Dr. Salonia will be discussing, is infection a common cause of male infertility? So if you haven't already registered for the events, you can do so on the events page at our website as well. So just leaves me to say thank you again for joining. Thank you to our wonderful speakers, to Professor Lewis, and of course to Francisca Mora and the team at Aria Fertility. So if you have any questions at all, don't hesitate to reach out, and we look forward to seeing you at our next event in October. Enjoy the rest of your evening.